The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to today's webinar. Our topic this week is helping the primary care system identify, plan, and care for seriously ill older adults living with frailty with Robin Urquhart. Before I introduce our presenter today, I want to go through a few housekeeping items and of course our CFN upcoming events. As usual, we'll have a Q&A that will follow today's presentation, and we ask you to please submit your questions online during the presentation, and we will try to answer as many as we can before our time is up today. Robin has agreed and has provided her email. It'll be on the last slide if we don't get through to all of the questions today. And Perry Kim, our Assistant Scientific, will host the Q&A session today. At the end of our webinar, a survey will pop up on your screen. This provides us with feedback on how to improve our webinar series and as well to provide feedback to Robin today. The webinar slides and the video will be available for viewing on our website, and the link is there on our screen, and it's usually up probably in 4 or 5 hours, but we usually say 24 to 48 hours. Upcoming webinars to register for on our website. We have the next two on our screen. One is supporting caregivers of older persons living with frailty and long-term care, and that's with Wendy Doubleby and Laura Cottrell. And on Wednesday, August 29th, we have the anticipatory long-term care electronic resident triage tool for long-term care homes, and that's with Michelle Grinham. So hopefully everyone will sign up. Next is our 2018 National Conference, and we hope that everyone will save the date. It's September 20th and 21st in Toronto, and the registration is open, and you'll see the link on the screen. It's also on our CFN website, and the link is there as well. And as part of that, our conference this year, we're doing something new. And that is on Thursday, September 20th. It is our Frailty Showcase. And we've had almost 80 applications that were submitted for this showcase, and all are in the review process right now. And we will have storyboards as well as presentations and an opportunity to ask questions to highlight the most innovative approaches to improving care for older Canadians living with frailty. So I'm thinking that will be a good event to attend. Finally, today's presenter is Robin Urquhart, and her project again is helping the primary care system identify, plan, and care for seriously older adults living with frailty. So Robin is an assistant professor in the Department of Surgery with cross-appointment in community health and epidemiology at Dal University. She's also an affiliate scientist with the Queen Elizabeth II Health Sciences Center. She's a senior scientist at Beatrice Hunter Cancer Research Institute. And Robin's primary research interests relate to understanding and optimizing the movement of evidence-based innovations into clinical practice, as well as the interface between evidence-based medicine and policy. Robin, I'm going to turn this over to you now to start your presentation.
Okay,
Robin?
do you see it? Yeah.
Thanks, Robin.
Okay. Perfect. Okay. Thank you very much, Carol. So I'm going to speak today. It's great actually to do this today and to talk to everyone about the work that we've done over the last number of years. I guess led out of Nova Scotia, but also Ontario, and team members from BC as well. And so what we're interested in has been sort of really this idea, and I'll get into it in a minute, but in terms of early identification in primary care, and really how we can help primary care sort of plan and care for, or better plan and care for older adults in their practice who are seriously ill and living with frailty. So before I go any further, I'd like to point out our research team. So we were funded by the Canadian Frailty Network a number of years ago. Both myself and Fred Burge co-led this work. So Fred is a primary care physician here in Halifax with also a big research program in primary care and end-of-life care. And you can see our co-investigators. There's quite a few there, and again, we're located in Nova Scotia, Ontario, and BC, and our local or our partners there as well from Nova Scotia. Okay, so I want to talk a little bit about this idea of early identification. We started this work with this first point, I think, was sort of our premise, was that early identification, or the identification of people who are approaching the end of life, maybe nearing the end of life, and who would benefit really from a palliative approach to care, is an essential first step toward delivering high quality palliative and then end of life care. And we know that the identification of these people, of those people who would benefit from a palliative approach, often occurs too late for proactive care plans to be put in place and carried out. So this can lead to suboptimal care in the last days and weeks of life. We also know that early identification has been associated with improved outcomes, and what I'm talking about there are things like coordination of care, access to needed services, fewer hospitalizations, more deaths in one's preferred place, enhanced bereavement support after death for family and friends, and so on. I suppose this was our next premise, and again, my co-lead Fred is a primary care physician, and we believe that primary health care, for a number of reasons, maybe primary health care providers may be well positioned to identify persons and initiate timely, person-centered conversations about end-of-life care. And this is really due to, primary care is upstream in our healthcare system, but also sort of oftentimes has long-standing, longitudinal, trusting relationships with patients and their families. We also do know that providers, and studies have shown us this, that providers are poor at identifying patients who are at risk of dying in the sort of near term and who might benefit from a palliative approach to care. And this is particularly true for non-cancer patients. So here's a study from quite a while ago now. I guess it was published in 2011, but it's a retrospective review. I'll take you through the figure in a minute, but it's a retrospective review of all patients who had died over a 12-month time period in a sentinel network of GP practices in the Netherlands. And so let's just here. So if we looked at everyone that had died over this 12-month time period, what we see here in sort of the purple, I guess, is that out of all those folks, 30% had never been recognized by their GP or identified by their GP as being close to death. And you can see here that, let me put the percentage up here, that really before the last month of life, so you can see, let's try and, I guess I can't really point here, or yeah, maybe you can see this. You can see here, this is no recognition before death. The blue is recognition less than 7 days before death, and so on. You can see the green is recognition more than 3 months before death. But what you can see in total is that 15%, death was recognized before the last month of life in only 15% of all patients. That's probably the easiest way to put that. And we can see that across all patients, really, if you look at the blue bars in particular, you can see that death in the near future, I guess, was recognized most frequently in the last week of life. So we have not been, as providers, I guess, that good at sort of identifying people before death, particularly in the non-cancer population. You can see there the difference with cancer as well. So in this study, recognizing death in the near future was strongly associated with only two factors, two variables, and that was a cancer diagnosis or limited functional state. So there are strategies, and many of you may be aware of them, that have been developed to try and help providers, and I'm talking about primary health care here today, so to help primary health care providers identify patients earlier in their disease trajectory or in their illness trajectory who are at risk of declining health and dying. So an example would be the SPICT tool out of the UK, and this is just one example. There are other strategies as well, and of course many people may know about the surprise question. But a lot of the identification methods out there have not been as successful as we have hoped. They're not really systematic in nature, and they rely on labor-intensive identification during the course of clinical care. So I just want to show you one study here before we get into the work we did. This is a study from 2013. It is a retrospective review of all patients who died in 9 Scottish general practices over a 1-year period. And basically, they were looking at whether these individuals were identified and put on sort of the register before death, whether they're identified as people who would benefit from a palliative approach to care. What these folks also did, what the researchers also did, was that in 3 practices, they did a retrospective, they basically used SPICT. They went back to the patient charts in 3 practices, and they used SPICT because what they wanted to do was estimate based on the chart data whether those patients would have actually been identified for palliative care and to be placed on the palliative register had the SPICT tool actually been used to assess their needs before death. So overall, in the 9 practices, it varied, but 26 to 50% of patients who died in that year were placed on the registry before death. You're not going to be able to see this very well, so I've sort of written out the important parts here. So the top graph are cancer patients, and in terms of the cancer patients' trajectory, they were diagnosed, those who died, they were diagnosed on average 27 weeks before death. 75% of those who died of cancer were identified before death and placed on the palliative registry. And they were identified a median of 7 weeks before death. And what the researchers found is that in those 3 practices is that the use of SPICT to assess needs before while the person was still alive would have increased identification from 77 to 88%. The next graph shows patients with organ failure and the trajectory. So those who had died of organ failure in those practices were diagnosed an average of 317 weeks before death. Only 19% of those were identified as people who would benefit from a palliative approach to care, and they were identified a median of 13 weeks before death. And you can see here that in those 3 practices where they went back and did the retrospective review with SPICT, use of SPICT would have increased identification from 28% to 80%. And the bottom graph here are the patients with frailty and dementia, And you can see again, diagnosed on average 159 weeks before death. 20% were identified and placed on the registry. They were identified a median of 2.5 or 2.4 weeks before death. And in those 3 practices, use of SPICT would have increased identification from 18 to 88%. So not bad, right? In terms of using a tool that can identify people as being maybe close or near to death, but also being people who might benefit from palliative care. So at the same time, again, when Fred and I were putting this together, there seemed to be very little known, I guess, about the perceptions of this concept of early identification. And certainly not much study about the implications of identifying people earlier again in the disease trajectory or in their illness trajectory. Just as an example, and many folks may have heard of this, but in the UK Dying Matters campaign in 2012, and folks may have heard about the Liverpool Care Pathway and so on. But this campaign aimed to help GPs identify the 1% of patients who are estimated to have less than 1 year of life in order to begin conversations and plans for end-of-life care. And this was certainly misconstrued, that's my word, but misconstrued in the media as sort of death lists and death registers and a way to save money for the NHS. So our objectives were really to test the feasibility of using primary health care EMR information to develop an electronic algorithm to help primary health care providers identify older patients. So we focused on people 65 years and older, older patients at risk of decline in health and dying, and then to explore the acceptability and implications of early identification in primary health care, including using an EMR algorithm to identify patients, again, who are at risk of declining health and dying. So I hope I'm going to take you through the methods of both Objective 1 and then Objective 2 and then go through the results. So Objective 1, it was again, the sort of testing the feasibility of developing this algorithm. It was a retrospective cohort study using mixed methods. So the setting was Nova Scotia. So the participants essentially, or the data we used, might be the best way to put that, was EMR data from 80 MARNet, so a network of primary care providers here in Nova Scotia. So 80 practices that were participating in the Canadian Primary Care Sentinel Surveillance Network. And we also did, I'll talk about this in a minute, 5 interviews with family physicians to get their thoughts on the algorithm, or on patients who were identified by the algorithm as high risk or not high risk. So in terms of algorithm development and statistical validation, what we ended up doing, I won't go through all of this and read it off, but what we ended up really doing was doing a lit search early on in our work to really look at what factors or variables in the literature tell us that are related to the need for end-of-life care, I guess. And that might be indicators of the need for end-of-life care. We also were aware of and work that was being done at the time in BC with Francis Lau and colleagues around sort of looking at EMR data in primary care and seeing what's available there around end-of-life care. So and Francis is a member of the team, and so we really were informed by their work as well. And that was done across the country, but led by Francis out of BC. And so we had a number of predictors that came from the literature review, and then we had, to look at what's actually available in EMRs. I guess is the way to put that. So essentially, in the end, we had various predictors that we looked at: demographics, essentially age and sex. Age at our index date and sex. We had comorbid conditions, a list of different comorbid conditions, as well as a comorbidity count, essentially, our multimorbidity count. We were able, using some work that I'd done previously with this team as well, looking at whether people were potentially frail or not. Looked at a number of different lab tests, whether there were abnormal lab results, but also the total lab tests that were received. And there were a number of different tests identified in the literature review as maybe indicating a need for end-of-life care or palliative care, or that someone would be at risk of sort of declining health and dying. We looked at total number of encounters, total number of prescriptions, and those were all in the 12 months prior. Our analysis essentially were Cox proportional hazard regression models. I don't feel like, from the regression weights, we plotted ROC curves and looked at area under the curve, which are C statistics, and looked at sort of optimal cutoff scores for sensitivity and specificity and so on. I guess it's not in there. We essentially had 2 cohorts from this data based on an index date, and so we developed this algorithm using one cohort, and we then validated it in another cohort. Then we did a little bit of clinical validation. So we went to 5 different providers here in Nova Scotia, and we randomly selected 20 patients from their practice, 10 that were identified by the algorithm as high risk and 10 as not high risk. And we asked providers to think about each patient's condition, and this is for our validation work, so the index date was January 1, 2015. So their condition around that time, followed by the surprise question. And we wanted to measure agreement between what the algorithm came up with, high risk or not high risk, and what the provider themselves responded in terms of the surprise question. Would you have been surprised if this person died in the next year? So I'm going to move ahead to sort of the methods for the second part of what we've done to try and look at, to explore the implications of doing this in practice and what people's views on early identification are. So that was a qualitative descriptive study using focus group methods. We had 6 in total that were supplemented by a small number of interviews. Just people couldn't get to the focus groups, and so we allowed them to participate in an interview. These happened in Nova Scotia and in Ontario. In total, we had 29 healthcare providers and policymakers, and they spanned from primary healthcare, palliative care, and geriatrics. The continuing care was there actually as well. And the analysis was a thematic analysis using constant comparative approach. Okay, so I'm going to go into some results. This is obviously from the algorithm development itself. I don't know how important this is right now, but you can see the eligible patients that we had in each cohort, how many deaths happened in those cohorts, year-long cohorts, and the proportion that were identified as high risk. This is probably more interesting, or I think so. And so you can see in our development algorithm and validation algorithm that, and I should say those I'm missing the thing right now. The superscripts basically indicate statistical significance, but at different levels. So the star is p less than 0.05, and the other one is p less than 0.001. So you can see here the things that came out as significant in our algorithm. Age at index date, sex, morbidity count came out in the second algorithm. It wasn't in the first. And total number of laboratory tests in the last 12 months. And those are the weights that are associated with those. You can see the sensitivity and specificity below. So in our validation algorithm, which again is right here, we ended up with a sensitivity in the end of 0.70 and a specificity of 0.677. And our C statistic, if anyone's interested, was 0.725. In terms of clinical validation, again, we compared the response to the surprise question against the algorithm. The kappa was 0.94. And what we ended up doing is we went to each of the practices, or those 5 physicians, and they had the list of those that were the patients in their practice that were identified as high risk and those not high risk. And what we had them do was actually kind of perform a think aloud exercise. And so as they considered that patient and their condition, they spoke aloud, and we captured all of that. And the reason I say that is because that qualitative sort of data allowed us to sort of explore, I guess, the reason for the discrepancy. And so really the reasons for discrepancy between sort of the response to the surprise question and what the algorithm said typically had to do with the patient's social support. So whether they were living alone, whether they're socially isolated, and so on. And of course, that's not something that we have in EMR data. Okay, so for the qualitative findings now, I want to go through this. I'm just checking my time. Okay, yeah, I want to go through this, and then we can have some discussion. So right in the beginning, really, the first thing that I would say is that in all of our qualitative work, this idea of early identification in primary health care came out as being acceptable to all of our stakeholders. And not kidding, all stakeholders found this acceptable and really thought that it was aligned with the values, the aims, and the positioning of primary health care. Again, I mean positioning of primary health care, meaning upstream, right? The upstream nature of primary care. And certainly sort of aligned with the longitudinal relationship that primary care providers have with their patients and families, and high levels of trust and rapport, and so on. Specific to the EMR algorithm itself, there were a few things that people that came across that our stakeholders thought were sort of facilitators, I suppose, and benefits of the algorithm, and there are a few challenges. So specific to this sort of idea of an EMR algorithm, the folks we talked to thought that it would be a very useful trigger because it's systematic and it's automatic and it does not require, again, work on their part in the context of a clinical encounter, right? They don't have to go through charts and try and map the person's condition against a tool such as a SPIC. Many thought that it would sort of objectively validate their own subjective perceptions, and that it would be a really useful tool to facilitate multidisciplinary discussions within the team. The challenges came down to three things that were discussed. One was this concept of flag fatigue. You know, there's so many kind of flags or triggers in EMRs already, and so if everything is important, then nothing's important. Issues of privacy, which patient privacy, and which really came up in our Ontario-based focus groups and not in our Nova Scotia ones. And then certainly the technical issues that would be involved in implementing this due to all the different EMRs we have across the country. This is just a quote here from one of our participants, and I can't really read it on my screen. I don't know if I can move this or not, but just one sec. All right. The one thing I think that we bring, that a family doctor does bring, is a very long relationship and therefore a very solid lever to ease them into the process. So next I'm going to talk about the next thing I'm going to talk about is this circle right here in terms of concerns with what to do after identification. So again, the stakeholders thought that, you know, primary care-based identification is acceptable. And so their concerns lay not in terms of identification, but then what's going to happen afterwards. And these concerns lay largely in two different areas. One was really around initiating conversations. So how do we then initiate conversations with our patients, so once they're identified, in ways that are sort of sensitive and responsive to patients themselves? And one of the implications there, quite broadly, was that more training is needed in terms of communication skills training and so on. The next sort of concern, the second, is that whether supports and services are available, particularly in the community, to help deliver a palliative approach to care after identification. So much discussion around, you know, provider supports are needed, but also patient and family-based supports are needed, and are those available now to be able to help us? So here's a quote from one participant again. We have a tool, so now we have to do something with it. Would it be possible to have an algorithm that leads you through what needs to be done after? Otherwise, you're overwhelmed with stuff. So the next thing I will talk about is sort of the changing and reframing here. So, the next big thing that came out of all of these discussions is that right now, the conversations that are had in primary care are often triggered in response to crises, right? Terminal diagnoses such as an advanced, metastatic cancer, crises, or sort of definable moments like a hospitalization. And so we need to change that. Again, we need to be more upstream in our identification and our conversations, and our conversations need to be an ongoing process that are then adapted to patients' changing needs and perhaps changing preferences. And the big thing here was the reframing. And so this idea that we need to reframe, and again, this is an algorithm around, in a way, time, right? I mean, it's based on putting someone in a high risk category of dying in the next 12 months. But we really need to reframe conversations away from, this is what our stakeholders were telling us, when a person dies or how long a person has left, to how a person dies and how a person lives in the time that they have left. So this is a quote again. It is really the journey, how you live well in that last 12 months. That needs to be the focus, I think. And how do we have that conversation, I think, rather than, the time is ticking. So the next big theme that came out of all of this is that early identification, if we're going to go down that path, and all of our subsequent conversations really require an integrated team approach. And this is critical inside primary health care, but also outside of primary health care. So inside primary health care, it was stressed that a team approach would mitigate capacity issues in the team, but also, and perhaps more importantly, leverage each person's skill set and their expertise. And then outside of primary health care, all providers in all sectors, whoever's caring for this patient and their family, need to be aware of things like advanced care plans, goals of care documents, the discussions that have happened, and this idea that any conversations that happen with the patient and family after identification are a part of everyone's job. Here's a comment specifically sort of around the inside of primary health care. We have kind of silo practices, and I can't help but feel that if you are on your own, those are very difficult conversations to have because it is not just a conversation, it is a number of conversations. It's a bit of a story that has to happen, and I can't help but feel that whatever the need of the team might be, a physician, social workers, nurse, whatever have you, I think you need to have that team around you as a physician to have these conversations. The second last thing that I'll talk about right now that came out of these focus groups was really that for patients, early identification will have implications beyond medical care. So in other words, it will prompt patients and their families to undertake life planning, I suppose, and to consider really what's important in their lives. And the implication of that really is that primary care providers who are starting these conversations have to be ready for those conversations as well and have to be ready to support patients in those conversations. And certainly from these stakeholders' perspectives and the providers' perspectives who care for these patients, is that the things that matter most to people are not medical in nature, but they're really related to spending more time with family, repairing relationships, and really finding emotional or spiritual closure. So here's a quote from one provider. I get caught up with the details of pain relief and whatever, and I don't sometimes stop to say, like the guy I saw the other day, you should get up to your cottage and enjoy it as much as you can. That didn't come out at all. And finally, this notion that a public health approach, it may not have always been termed a public health approach, but this notion or this concept that a public health approach is really needed if we're going to optimize early identification and really optimize its impact for patients, its positive impact or its beneficial impact for patients and families. And the idea that was discussed in these focus groups and that came out over and over again was that end-of-life care really needs to be approached as a social issue rather than simply purely a medical issue, and that we need to engage our communities if we're truly going to improve care and outcomes for people as their health declines and as they approach the end of life. So here is a quote from one of our participants. If we are looking at being progressive about this, do we look at the broader social determinants of health? Do we look at community leaders and how do we influence them so that they are now saying, oh wait, as a community, we know that we have a number of individuals who are not doing so well. I think that there is a really big opportunity to think differently than we traditionally have. Okay, so just a couple of key points that I'll just say from all of this work, and I've just presented a couple of pieces. I mean, two of the main pieces, I suppose, of our work, but we also did some more data collection in addition to what I've talked about. And we also took all of this work to, we synthesized it all and we integrated it with what we know in the literature. And we took it and hosted a number of stakeholder dialogues in Ontario and Nova Scotia to get stakeholders input, I guess, and direction on where to go next with this. So that was all sort of really interesting work. And one of the trainees on the team is putting in an abstract around that for the CFN conference in September. So key points, I'll get back to this slide. Routinely collected EMR data in primary care shows promise toward developing an early identification algorithm. There were a number of challenges, not surprisingly, and there are data that are not available right now in EMRs, you know, particularly around the social aspects of the patient's life and I guess housing and whether they live alone and things like that. Early identification in primary health care is viewed as acceptable to most stakeholders based on the data that we have, and viewed as acceptable. So I alluded to we had done other work. We also done interviews with patients, so people who had declining health and frailty, and then family members as well of sort of family friend caregivers of individuals who sort of had declining health and declining functional health or frailty. And early identification was also viewed as acceptable to those folks. And certainly from the work with the policymakers and the providers that we've done, the concerns lay not in identification per se, but in what to do after identification. And again, I didn't present the data from patients and families, but that came out strongly there as well. It's not so much in the identification. It's in, okay, so what supports and services will be available to me after identification to make sure that, you know, I live as well as I can in the time that I have left. So I'm going to end just on this slide because I just want to show you some work that's come out of the UK that's been quite similar. And this came out after we started on our project, actually. But this was published after we started our project. And again, it was sort of a group led by Bruce Mason and colleagues, Scott Murray and so on, out of the UK. And what they were trying to do was very similar, trying to see if they can develop a computerized search to help general practices identify more patients for palliative care planning. So this was published, I think, 2015, but it was after we started our stuff. And basically what they found, again, it's possible to run a search of existing electronic primary care records to identify patients with deteriorating health. So we've shown, I think, possible in the UK, possible here. However, what they found, and they did go to primary care providers as well to get their sort of input on how they might use the results to sort of improve care in their practice. And what they found was a resistance among primary care teams to expanding patient identification in this way, and a reluctance to introduce palliative care at an earlier stage than current. Again, because of this sort of widespread association with terminal care and, you know, afraid of patients losing hope and giving up. And so again, this was sort of their conclusion, but that recent controversies, which I alluded to earlier, over sort of identifying patients in this way, should cause us to consider benefits and potential harms of identifying relevant individuals and then how we can do it better. So I think I bring this up only because this has been done elsewhere in terms of developing a computerized search. It's been shown feasible. And, you know, I think we addressed some of this, trying to figure out people's perspectives on early identification and some implications that would have and so on. But I do think it's an important area to consider if we go down this path, and just not whether we do it or not. I don't mean it as much there, but just how we can make sure we do it in the best way possible. So I'm going to stop there. I hope I didn't take up too much time, and then just open it up for questions.
Hi, Robin. This is Perry. Thanks for your talk. It was great to hear some feedback from the stakeholders as well as the clinicians and so forth. As we wait for questions to come in, and I'll encourage all the listeners to please input your questions on the side panel there. As you'll see, there's a question box that you could type in your questions, and we'd be happy to relay those to Robin. Robin, as we wait for questions to come in, this gives me the opportunity to ask some questions, I suppose. And so one of the things that surprised me from your qualitative data was that clinicians seem to really accept the idea that primary care is sort of the place at which some of this initial sort of assessment could be done, and in terms of risk assessment, mortality.
Yeah.
That surprised me a bit because just listening to the literature out there in terms of the time physicians have, primary care physicians have, and other clinicians have in terms of sort of the interaction with the patient and so forth. And we hear all these stories of that time being on average somewhere between 10 and 15 minutes. And now you're talking about putting in a system where if by the very nature of the discussion, you would have to spend a considerable amount of time to sort of really properly speak with the patient and so forth. Did that surprise you in terms of the clinician acceptance of this algorithm and their role?
So I don't know. I've thought about this because I don't know if it surprised me greatly, but I think there are a few sort of nuances and so on. So one is certainly challenges were brought up, and time was one of them. Although time, but also again, this sort of comes under what to do next, right? Is discomfort with having these conversations, or I don't know if I want to say discomfort, but certainly not high confidence in having them. And so this goes down to one of the big things that I sort of just talked about quickly was this idea that they want to improve capacity, they want more training. That came out in the focus groups around how to have these conversations, and so that I feel much more comfortable. But it also came out, the time piece in particular, plus the skill piece, came out in this idea of a team approach in primary care, right? So if everybody's involved or everybody has a part to play in having these conversations, and it may be a stepped approach, that sort of a pathway approach, a stepped approach to having these conversations where different people have a different role to play, then that helps with the time issue. But it also helps leverage everybody's expertise, right? So a social worker within the, if you have a practice where you have, a social worker and a nurse or an RN and your primary care sort of physicians or nurse practitioners, and you have a pharmacist on your team or something, everybody can take a different piece of that and take what sort of fits with their expertise. And so that was sort of how it was framed in our discussions, actually, is that of course there's a time issue, but if we truly wanted to do this and we took a team approach, we would be able to do it. The other thing that came out in a number, not all of the focus groups, but in a number of them that we had done here in Nova Scotia, and I had facilitated those, is that this idea, as they're talking, that it saves time later. So if you take time to do this now and do it right and have these conversations, it saves you time down the road when crises happen or when the patient's health deteriorates, very quickly and things like that. So that notion of doing something now to clearly to improve care and that sort of thing, but if you anticipate what might happen, you actually save yourself a lot of sort of time and grief later as a provider.
That's a great point. I'm curious in terms of the training aspects, what's your feelings about, again, we hear a lot about how maybe certain clinicians may or may not communicate as well as one should, or show empathy and so forth. And I don't know if that's true or not, but in terms of this approach that you're advocating, what do you see more training at the sort of medical school level, so forth, so that they're well prepared for sort of this potential new role of using EMR systems to assess risk and so forth?
So I would say right off the bat, I would be clearly an advocate for more training at the medical school level. Now, being involved in some of the medical school curriculum here, I understand that everybody's trying to get more training for everything, right? Like more time within the curriculum for everything. But I do think actually there is a role to play at the medical school level, also at the it's a residency training level. And so as a part of another project, I had done sort of a scan of what's available formally and sort of informally, the bedside teaching, I guess, at the resident level here at Dalhousie in terms of having being trained in these conversations. And very few residency programs have any formal training around this, right? So I think within residency as well. I do think, I've had conversations with folks in the medical school here at Dal, and some other people that I work with on other projects, but that are all related to sort of communication skills training and so on. That we're also sort of trying to reframe it even at the medical school level, so that they're not called difficult conversations anymore. So that they're called, critical conversations or important conversations, rather than framing them as difficult, because I do think words matter. And so if you introduce something as a difficult conversation in year 1 or 2 of medical school, then it becomes a difficult conversation, right?
Right.
And so I think that's important. But yes, I would be an advocate for more of this training. In the focus groups that I just presented on, I asked the question because a lot of discussion was around sort of lack of comfort and not a lot of confidence in primary care in particular, and that varies. Some primary care providers will have very high confidence depending on their practice and just themselves, I suppose. But overall, high discomfort with starting these conversations. And so then I had asked in the focus groups each of them, what do you think? Like, do you think you would benefit from communication skills training? And I have to say, everybody around the table just sort of nods their head and doesn't say anything, right? And then one participant had said, and this won't be a complete verbatim quote, but essentially had said, I think you never get enough of this training.
Yeah, that's absolutely true, I think.
Yeah.
Well, thanks, Robin. We've got a number of questions coming in now, and some are sort of more in terms of the actual study specific. So I'll read some of the questions verbatim.
Okay.
Thank you very much for this presentation. Very timely and interesting work. How did you operationally define potentially frail based on the EMR data? Was this explicitly recorded in the chart, or was it based on certain statements or notes?
Yeah, no, it was not. So, as we know, like frail is not a diagnosis associated with the diagnosis code, right? So no, we did not. What we ended up doing was using, to the best of our ability, some work that we were involved in on a CFN-funded project before, actually. That Anik Giguère was leading, but sort of myself and Bev Lawson on this work had sort of been really highly involved in developing sort of rules to identify people with frailty in administrative health databases, so billings and CIHI discharge abstract databases. So we had done that work before embarking on this, and so we used that to the best of our ability to sort of come up with a measure that we called potentially frail. But essentially, they had to have 2 or more of things that are in the Edmonton Frail scale that we looked for. So impaired cognition, incontinence, falls, nutrition issues, so on and so decline in function, like functional performance, and so on. or sort of targeted health service utilization that again are in those sort of decision rules that we developed, but things like home visits, geriatric billing claims, and so on. So it was a sort of a decision rule where we were looking for two or more of these things to call a person or to define a person as potentially frail.
I see. This next question goes to a number of different sort of comments that I see here in terms of frailty. Again, basically wondering, or the questions are sort of framed around maybe identifying frailty more systematically or sort of more defined to reframe and help to improve the outcome. So is that something that you think would help the algorithm? And if so, then how do you see that playing out?
So I do think it would help the algorithm. So just as an example, there has been quite a bit of work done in Nova Scotia, concurrent to this also, actually, and I know there's been work funded by CFN around the implementation of it, around a frailty portal in primary care. So again, where primary care providers, using the tools are embedded in EMRs, sort of screen for and assess for frailty, and then plan accordingly. And so that data, which were not available in the EMRs when we were using them, if that frailty portal gets more uptake and they are embedded in EMRs, we'll have a more systematic way to actually assess for and capture frailty, which I think is a great thing. And that's been been an ongoing, concurrent with this work here in Nova Scotia, at least an ongoing project of our health authority is to embed frailty portals into primary health care, where you would screen for frailty and so on. So I think that is very important. Now, if I'm going to go back, or can I go back here? I'm going to go back and point out something that we don't exactly know what's going on right here. So let's see potentially frail here. So it didn't come out as significant in either of the models. You can see that the direction changed throughout our development to our validation algorithm. We don't know why that happened. Like, this is one of the things we've sort of racking our brain around. However, what we did notice both with this variable as well as with the morbidity count is that so the validation algorithm is later in time, a number of years later in time. And so the data in the EMR were much better. Like, providers were getting better at entering data. Our thought is at entering their sort of information, the patient information and data into the EMRs over time. And so I think that over time we will have hopefully a better ability to be able to identify people maybe as potentially frail. If we were to go back today, I think, and use the same decision rules, I think we'd be better at that using EMR data. But I actually think if we embedded in our EMR screening assessments for frailty, I mean, then we'd have the data, right?
Right, absolutely. Interesting. And related to that, Robin, something that sort of popped into my mind was some of the work that we funded with respect to inter-RI home care assessments and other instruments that, and how those instruments are being used sort of in a similar fashion in terms of assessing for frailty and then sort of risk assessment for morbidity and put death within a certain period of time. How do you envision that sort of that data being reconciled with the primary care algorithm and so forth?
Well, that's a great question. How do you, with all of not only the different EMRs that exist in our context today, and I know that people would say I'm lucky in Nova Scotia because we have fewer EMRs than in Ontario, for example, like fewer types of EMRs software than in Ontario and other provinces. But with the plethora of EMRs and then every other sort of clinical database across sectors, I mean, how do you, is the question more in terms of envision how we could sort of use all of that data together, or I mean, it's about a linking data sets in any sort of prospective real-time way is, you know, there's various challenges at various different levels, including sort of at a regulatory level with that, I guess. I mean, in Nova Scotia, we are going towards one patient, one record, which like would be, you know, absolutely fabulous and fantastic. And I'll say when we get it. So all of our data, there will only be one record for each patient in our province. And so I'm not sure, maybe I misunderstood the question, but was it around sort of how do you leverage continuing care, like home care data alongside primary care data? Because the challenges in terms of right from technically, even though I don't think most of the time it's a technical challenge, I think the policy or challenge are quite big. I don't know what the context is in other provinces other than the Atlantic provinces, to tell you the truth, around being able to use multiple data sets in any sort of prospective way for clinical care versus a
Yeah, no, that was exactly
Okay.
was exactly what I was getting at, and more the notion that just the idea that when one has this relationship with a patient, it could be expanded to sort of the home care setting, and therefore that conversation is ongoing.
Yeah.
And obviously, their needs are met because you know their values and wishes as well.
Yeah, and that's, I think, from our perspective, just putting on this sort of idea about, you know, I'll say palliative care, or providing a palliative approach to care, and our strategy in our province. So in Nova Scotia, we have a provincial palliative care strategy, and it is rooted in primary care. It's not rooted in specialist palliative care. It's rooted in primary care. Now, of course, specialist palliative care will always be around, and we need them, and that sort of thing. I don't mean to say it like that, but essentially, you know, trying to improve capacity in primary care to do what can be done. But all of that will be like when we eventually get this one patient, one record, many of the challenges I think that we face now in this area, you know, if you just think about also like goals of care designations, if you do that at in one sector, in one, you know, physician's office, is that, or whomever, one care provider's office, not only, you know, are the rest of the care team providers in that setting, is it being communicated to them, but I mean the challenges of it being communicated across sectors, right? Continuing care, acute care, and so on and so forth, which is the whole push to having a patient responsible for it, right? Like the green sleeves in Alberta and that sort of thing, because we just don't have that integration of data and flow of information across different sectors.
Yeah, Robin, I think there are so many challenges across all provinces on data integration and settings of care and all of that. But
I mean, it would be wonderful.
Yeah, it would be wonderful if we could solve that in the near future, but it seems like it takes quite a while to do. But thank you, and Perry, for answering all the questions today. We're running out of time, and you might have about 1 minute if you have anything further to add on your thoughts before we end today's webinar.
I don't think so. The only thing I'll say is we did these stakeholder dialogues, and perhaps I should have put a little bit in there about it, but it was interesting to me, and I'll sum it up in that the number one recommendation that came out across those dialogues, both in Nova Scotia as well as in Ontario, was the idea of having sort of community-based, different terms were used, and navigator was used here, and I think it was liaison in Ontario, but having community-based, some sort of healthcare worker, I guess, to really help patients, families, and primary healthcare providers navigate the system, and how important that navigational aspect is for flow of information, for accessing services, and so on. So I'll say that. So if anybody wants to see a copy of the summary of our dialogues, which we have, then just email me, and I can email that out to you.
That would be great. And I think we have a few projects working in that area right now on patient navigation.
Yeah, it was
But I think yeah, so go ahead, sorry.
No, I said no. It's interesting that in both provinces, that's what came out. So I just put my email up. If anybody wanted to see a copy of that, just email me and I'll email the PDF.
If anybody has any follow-up questions, there's Robin email on the screen, and we will be putting this up in the next 24 hours to 48 hours. So you'll see everything you've seen today. You'll be able to either listen to or see again. So thank you, Robin, for your presentation and all the questions you got today. And thanks for everyone for joining our webinar today, and hope you'll join us in the next webinar on Wednesday, August 15th. So that ends our webinar today, and I hope everyone has a great rest of the day. Bye for now.